When people ask why I climb, it's easy. To get to the top. Collaboration with the right partner is everything when it comes to the ascent.
Employers rely on us every day to be their team. We partner with organizations to protect what's most important, the promise of a secure future. We will help you on the climb because we are committed to seeing you reach the summit. The only thing you have to do is take the first step.
Hello, good afternoon. I'm Todd Rowland, President of Summit Financial Group. We specialize in insurance, investments, and benefits. We at Summit are pleased to sponsor this session for bigBANG for our this 9th consecutive year. We're also especially pleased to be involved in sponsoring this session, Equity in Healthcare. This is a very important topic to us as a firm. We're very familiar with the fact that we're running in the United States at 17 to 18% of the GDP in terms of healthcare spending here in the U.S. And we're also very aware of influencers like social detriments to healthcare and how they're affecting how that affects easy access for our population. So I couldn't be more pleased with our panelists, who I know are going to be able to speak to a lot of these issues. We have several locations throughout the country, but this session is particularly important to us because our home office is headquartered in Dallas, Texas. And as a result, we have keen interest in this. So I appreciate your attention today, appreciate your participation. And at this point, Lenore, I'll turn it over to you.
Hi, good afternoon. My name is Lenore Marquez. I'm the CEO for Los Barrios Unidos Community Clinic, and I have the pleasure of moderating this panel on healthcare equity. We were talking just now that we were wishing it was 2 or 3 hours or 2 or 3 days, but we've got 45 minutes, but we're going to make the most of it. And I'd like to just jump right in. I'd like to start with Anne. What can you tell us about the connection between health insurance coverage and racial and ethnic disparities in Texas?
Well, thanks, Lenore, and I'm really happy to be here. I'm going to go ahead and jump to share my screen on a couple of things. And while I'm doing that, because it takes a couple of steps to get there. There we go. First, I would just show you, they will make these slides available to you guys later. So, you don't have to catch every detail, and I'm going to kind of fly through them. But one of the things that I wanted to call everyone's attention to is the fact that it is absolutely the case that what I'm going to talk about is really kind of the economic opportunity and consumer protection sort of issues around, mostly around equity. And that's just one piece of it. Obviously, there's a huge body of important research around sort of the clinical, I apologize for that, the clinical pieces of equity related to health. And some of that, and I think we will have a chance to talk about this too. So I'm just going to fly through a couple of things about the uninsured. Just a reminder, most people on this webinar probably already know that, but Texas does have the largest number and the highest percentage of uninsured in the United States. And, you can go into the details on these slides later if you'd like, but the sad part is that we really made some historic progress for a couple of years, and then we've had a worsening in the last couple of years. And so we're very concerned about that. And I wanted to share the little block that shows you the difference in age groups. It's kind of counterintuitive, but working adults are, almost twice as likely to be uninsured as kids in Texas, even though they have access to employer-sponsored coverage. What adults in Texas don't have very much access to is Medicaid. And so we'll touch on that too. But moving on to race equity, I'm going to show you a graphic in a minute too. I wanted you guys to have this spreadsheet to go back and look at, because it's from last year's census data. And basically one of the big jump out factors here is that Hispanic Texans make up 40% of our state population, but they make up 60% of our uninsured. And then when we look at Black non-Hispanic Texans, they are actually slightly underrepresented in terms of the uninsured rate, which does not mean there aren't other economic barriers, obviously, for Black Texans, but that the biggest and most glaring issue we see in terms of race and ethnicity really is affecting our Hispanic Texans. And again, you can come back and look at all these numbers later, and you'll see that, you know, the problem is even starker for our working age adults than it is for kids. This is something I wanted to show you, is that, you know, there's a good news, bad news scenario. The Affordable Care Act helped bring down our uninsured rate. And I'm sorry I don't have this with more years on it, but it would show a little bit of a loss of that progress if we added the last 2 years. But the bottom line is, when you break it out into race and ethnicity groups, you see progress across the board, but you haven't eliminated the disparity. Excuse me. So when we start talking about, you know, wanting to look at solutions that could not just improve everybody, but to get rid of the disparity altogether, that's what, you know, we would like to see, one curve that kind of matches for all those groups. One of the things to keep in mind is that our uninsured issue has gotten even worse because of COVID-19, more so because of the economic consequences of COVID-19. So at a time when arguably people need coverage more than ever, we have 3.7 million Texans who applied for unemployment, and a subset of those lost employer-sponsored coverage in the process. So one of the things that we're concerned about is that come January, for example, when our legislature comes back, we think that there will actually be quite a few more uninsured, you know, than our census data for 2019 told us, and that we will have had a substantial increase in the uninsured adults who could qualify for Medicaid expansion. And I think maybe we'll jump back to, I guess one other thing I want to show you is this is our Medicaid population in Texas. A lot of folks are not aware of the fact that our Medicaid program is vastly dominantly children. So we have, you know, children who are just eligible based on their income, but we also have children who are eligible based on a disability. And then there's a separate, much smaller program called the Children's Health Insurance Program that picks up slightly higher income folks. But as you can see, unless you're elderly or disabled, or during a pregnancy, there's not much coverage of adults. And this is how you end up with, you know, 3.2 million Texas children getting Medicaid, but only around 150,000 parents getting it. The parents' income cap was set by our legislature in 1985, and it's never come up. So that's how a state ends up in that situation with so many kids and so few parents. This is why the Medicaid expansion conversation is so controversial, you know, is that we have left not only parents of our kids on Medicaid, but also adults who don't have dependent kids at home without the ability to get coverage from the ACA. And I'm not going to walk you through the whole, this is a fact sheet from the Kaiser Family Foundation. I'm not going to walk you through the whole thing, but I wanted to make you aware that it's there and it's fairly easy to find. And one of the helpful things they pointed out is that, you know, 74% of the uninsured adults in Texas who could get picked up by a Medicaid expansion are in fact people of color, predominantly Hispanic, but also with a significant Black component, and then you know, a mixture of other racial and ethnic groups. So I think I will stop sharing my screen, and if your ears aren't bleeding now, head it back to Lenore.
Thank you, Anne. Really, really good information. And thank you for talking about the Medicaid expansion, potential Medicaid expansion, because that will look different, right? The pie graph will look different. It is a women and children's program, and it would be nice if there were more adults covered on that. So thank you for talking about that. So Yolanda, also a queen of good data and good information. Tell us about some facts and myths about health inequities, please.
Sure. Thanks, Lenore. And let me just say thank you. It's awesome to be part of this great panel. I'm going to go ahead and share my screen to you. And In the meantime, though, I think it's important that we get started with acknowledging that, systemic racism is a public health crisis in the U.S. And it's one primary driver of, let me make sure I can grab the screen. It's one primary driver of of racial and ethnic disparities. Let me see. Can you see my screen now? Okay.
Not yet. Yes, now we can.
Okay, and can you see my slides?
Yes.
Okay, so and therefore health equity is actually should be a public health priority. So at PCCI, what we do is we leverage clinical expertise, data science, and social determinants of health to meet those needs. And when it comes to health inequities, we are very much focused in understanding what are the drivers and key factors, known facts, and these are things that are of public knowledge, are that Blacks and Latinx are more likely than white to have chronic diseases, but also that Black women have about a 50% higher risk of ending up with a preterm delivery, which is a bad outcome, and Latinx about 10% than white. So we know that that's a fact about racial and ethnic disparities in health. But then, once this comes up, the usual answer is, but it could be due to genes, it could be due to culture, to the way people live. That might be why there are differences. Well, the other fact to counter that is that when you look at the data, 90% of racial ethnic inequities can be explained by socioeconomic disparities alone.
Yes.
So those are the primary drivers. And then the question, the next myth is, expanding health insurance coverage, improving healthcare quality, closing up this equity gap is going to break the system. It's going to overwhelm the system. Well, the answer again here is no. We have natural experiments and we have analytics that show us that affordable and equitable healthcare pays for itself. For instance, disparities in hypertension cost about $35 billion every year in excessive healthcare expenditures and $10 billion in lost productivity alone. And it's been demonstrated and calculated and modeled that improving appropriate asthma treatment by 10% among Black workers would save $1,600 per year per person. So with this data, we knew that affordable and equitable health is not just a moral imperative, it's actually an economic imperative. Health equity can pay for itself and it's worth looking into. Leno, I'm going to go ahead and stop sharing and give it back to you.
I love that moral imperative. Of course, that resonates with me, but there's also an economic imperative. It makes economic sense for Medicaid expansion in Texas. And I'm very, very pleased that we have Texas legislators talking about that now. It's not such a foreign concept anymore. So one could say that we have the best healthcare in the world, in this country. We're awfully proud of that. And in this city, where we are, miles away from one of the best medical schools in the world. And what does that mean? How available is that excellent healthcare, and how available is it to people without insurance? So, Anne, if you could talk a little bit about that. We're talking about a coverage gap, or are we talking about, this is the life of the working poor? You're muted.
Muted. Sorry about that. I want to go ahead and jump back over to sharing my screen. And I'm sorry, you guys, that I'm not more adept at this, but I promise you I'll get better at it. I'm telling it to open. There we go. So basically, if I can get my slides to advance. Alrighty. Some of the things that we wanted to talk about were in terms of access. Well, obviously, we already shared some of the information about the racial and ethnic breakout of the uninsured, as well as the even higher numbers related to that population that is like the working poor in Texas, who are excluded from Medicaid and who cannot get most of them, a majority of them cannot get coverage under the ACA. But we also have some issues that are obviously been reported on, but I thought it'd be useful to share some numbers with respect to COVID-19 mortality. And so I was going to share that first. This is from our state Department of State Health Services. And one of the reasons that we're looking at fatalities as opposed to cases is that it turns out that we've got testing data coming in from so many different sources that there's large amounts of the case reporting doesn't include any racial or ethnic demographic information. And so those numbers for cases are not really a reliable source of looking at the actual distribution of who's showing up with positive cases, unfortunately. I just don't think we almost would have had to have a system invented in advance statewide in order to collect that efficiently. But sadly, the death records, the death certificates do keep track of that. And you can see that our Hispanic, the 55 Hispanic deaths from COVID-19 in Texas, make up 56% of our deaths have been among Hispanic Texans. And again, if we'll remember from our health insurance slides, Hispanics make up only 40% of the population when you're looking across all age groups. So I apologize if that isn't exactly the question that you were wanting me to answer there. I may have gotten my notes a little confused on.
You're good. I think that issue of medical debt is really important. I will say that at Los Padres Unidos, we see a lot of working poor Latinos. And one of the things that is extremely troublesome to our patient population these days is the fact that they haven't been able to pay their bill with their cash right up front. Because at the beginning we said, no, we're going to make it safe. We're going to make it easy. Don't worry about paying. We're going to send you a bill. That is so troubling to so many people, working poor people who are used to paying cash up front. And so to have a bill, and we're talking about tiny debt. So when you're talking about monumental debt, risk of losing your home kind of debt, that's very, very troublesome. And it becomes a health issue.
Again, I'm very guilty of putting too much detail in these slides, but I'm hoping that the folks who are participating will, who are interested, will have a chance to look at them later. And the data we have on medical debt comes from one of the largest credit agencies. It's good data. They have it available at the state level and even down at the county level in many cases. And just overall, Texans have a higher rates of medical debt and higher rates of credit card debt than the nation in general. And those are the kinds of things that make people reluctant to follow up on care for chronic conditions. If they're carrying something that's explicitly medical debt, it's a medical bill that wasn't paid, or a giant credit card debt that is because they use their credit cards to pay those bills. And as the stats show, it is very disproportionately carried by Texans of color.
Yes. Okay. No, thank you, Anne. So if I can kind of shift gears a little bit, Yolanda, tell us a little bit more of how you or your organization uses data to enhance health equity. So, and what challenges does that pose to successfully addressing health inequities?
Sure. Thanks, Eleanor. So I'm going to share my screen again because I think it's useful to be guided by visuals here. So I'm just going to tell a story of how we analyze COVID-19 yet again to identify areas with social and ethnic inequities. So let me know if you see my screen.
Yes, we can see it now.
That's awesome.
Nice.
So, so the way we use data typically is to emphasize the looking at specific racial and ethnic disparities observing those and measuring those intentionally. And one example is when we looked at trying to understand what's happening in Dallas County in terms of COVID-19 risk. And we're talking about the risk of infection, I'm talking about mortality. We didn't have the racial ethnic reports, public reports, just like Anne mentioned. Yet we had access to some other data sources that could allow us at the zip code or at the neighborhood level to identify what neighborhoods have a higher percentage of specific race and ethnicity. We also pull data from other sources to look at, what's the burden of comorbidities, and then we correlated that in addition to the burden of, social deprivation. We have this index, the area deprivation index, that's publicly available. That's published at the blog group level. So we could pick that information and try to correlate it with the risk for COVID. And what we found was that there were racial and ethnic disparities in Dallas County. And the data showed it, even if we didn't have the direct reports from the test results, we could show it based on neighborhood level data. So we typically want to understand why. It's important to understand if there's anything actionable about it besides, like, beyond knowing that specific races and ethnicities are involved. So what we did was to look at, sorry, my computer is causing trouble right here. Let me snooze this. Can you still see my screen? I'm going to move this aside. So what we did was we then started asking the question: is it because we have a higher percentage of African Americans or Hispanics who have chronic conditions? And what we found was that, well, chronic conditions, and that's the data right here in the middle, the column right there in the middle. Chronic conditions were not the reason why there were differences across races and ethnicities, because when you looked at neighborhoods with similar levels of chronic conditions, you would still see those differences. So the next question was, is it because of any social risk? And that's the third column right here. And you can see that, yes. So let me explain why. Here you can see that Hispanics, of course, had the highest risk of COVID-19 infection, African Americans second, whites, and then the other races and ethnicity. However, once you controlled for social deprivation, once you started comparing neighborhoods with similar levels of social risk, well, the differences actually shrunk. Now, you could see that, for instance, the risk for white folks went up to 78%, which decreases the disparities. It means here that, social deprivation is a primary driver of these differences. And why is this important? Because it gives folks, insight into what can be done to improve these outcomes. For instance, these classification, these risk stratification allowed the community to identify areas that were at high risk, yet were very deficient in testing sites. And we put some testing sites over there. It was used to drive home testing, community health worker deployment in the community, and it's currently being used to try to plan for vaccine prioritization. So that's truly the way we use data to help with solving the problem of health equity in Texas, by giving insights and actionable information to the frontline folks, the people who can make decisions, so that we can drive insightful and impactful interventions. Let me stop sharing.
Outstanding. I do want to talk more about the impact on Black and Brown communities that COVID have had. As we know, there's health disparities and have been for decades, for as long as there's been people, I suppose. But Anne, could you say a little bit more about those disparities here in the time of COVID? What are you seeing?
Well, I probably kind of jumped ahead of myself on that last slide, where we showed that the mortality rate is looking very disproportionately high for Hispanic Texans. And so I would want to make a point out of that. And I think there's a lot of issues in there. Some of it involves the lack of as clear and strong a statewide public health message coming from the top as could be. we've had, obviously we know there are, and I think Yolanda is probably can speak better to that than I can, but we know that there are the socioeconomic factors that could potentially lead you to overcrowding, to having to go back to work, to being an essential worker, that those are all potentially higher for lower income communities, and our populations of color are disproportionately lower income communities. So there really is kind of a double whammy there. We have other factors that I would note are that where you get tested, how you can get tested, who can get tested, where you find a free test if you're uninsured. All of these things are different in every part of the state. And so one of the challenges Texans have is figuring out, when am I supposed to get a test? And in my community, who do I have to call? Do I need a doctor's referral? So I think the lack of as strong a message that is really being pushed out through all trusted community kinds of resources is something we've really kind of missed the boat on, probably not just in Texas, but around the country. Another thing that we have noticed is a lot of people don't realize it, but just over 1 in 4 Texas children has a non-citizen parent. So that could be a parent who has a green card, who's lawfully present, or an undocumented parent. And what that means is there may only be one person in that family who's not a U.S. citizen, but the whole family sometimes can be scared away from accessing healthcare services because they're concerned about the consequences for that other person. So when you talk about, 1/4 of the families with children in Texas, there's a lot there. And one of the things we just haven't done a fabulous job of in Texas is really getting the word out that testing is available regardless of immigration status or citizenship, and that none of that stuff will be held against you if you're trying to move through the lawful immigration process. That's kind of a little bit in the weeds, but we're talking about a lot of people in Texas. I think we estimate that around 6 million Texans are in a household with a non-citizen member. So that means there's a lot more people than just the individual who's not a citizen who potentially get affected when we don't weave that kind of really proactive, encouraging message into our public health messages statewide.
Okay. I think that's such a good point. Just the messaging, it is extremely challenging to get the message out, okay? Because adult learners learn it a variety of different ways. And very few of us learn because they read it once, got it. You literally have to speak their language and at their level. And personally, I'm educated, I'm reasonably intelligent, but I get intimidated when I see long paragraphs of things. But if I see kind of shorter things, I'm like, okay, I get it. It's not as intimidating. So our messaging, welcome back, Yolanda. So I get it. The messaging is very hard. And I will tell you that as a CEO of an organization of 220 employees, healthcare workers, mind you, and pretty enlightened healthcare workers, it is a constant challenge to keep them informed on some of the PPE requirements and the distancing and, okay, what are we going to do for Halloween and Dia de los Muertos and Las Posadas at Christmas time and all that. I mean, we're saying it, we're doing it, we're putting it in our Facebook. It's no joke. It's very, very challenging, and people still aren't getting the message. So we are just constantly challenged with that. We need to get better and better at that. So Yolanda, I know you had tech troubles there for a little bit, but anything else to add on sort of the response, the COVID response, or the impact on brown and black communities? Whoops, we can't hear you now.
Oh dear.
My goodness. Whatever it was she's saying, it's brilliant too. So okay, you know what? We're gonna march forward, Yolanda, but just pipe in, and then when we hear you, we'll have you speak. I know that at Los Barrios Unidos Community Clinic, our patients are the people who are hit with disparities. Community health centers, FQHCs, such as Los Barrios Unidos, exist because of disparities. We are located in poor communities. We cater to people without health insurance. We'll take people with insurance, but we literally speak their language, Spanish, Vietnamese. If we don't speak it, if we don't have someone on our staff, we will find a language line or a program to talk with folks. Deal with people a lot who don't have a lot of resources, don't have a lot of, if they don't have health insurance, maybe they feel embarrassed because they can't even pay their copay or their sliding fee scale. All of those things are barriers, not because we set them, because the family is embarrassed or coming in. So we like to think that we work on those things every day, okay? And just the way we operate, and even in the time of COVID, especially in the time of COVID, what are we doing to make healthcare accessible, more accessible? For example, low insurance, the vast majority of our people do not have health insurance. For the adults, it's like 95% of the adults walking through our doors do not have health insurance. Again, no problem. We will still see you. And it's going to be very high quality care. We're Joint Commission accredited, so the clinical bar is very high. We take very good care of folks. Is it hard for you to pay for your medication? No problem. We operate our own pharmacy, a Class A pharmacy licensed by the state with very affordable prescription medication. Okay. So again, if you've got no resources, okay, well, you've got a prescription, but now you can't pay for it. Now you can't get it. That community health center can help you with that. So, we exist because of all of those barriers, and we're part of the answer for reducing them. But much bigger things like increasing the number of insured and making healthcare even more accessible in more neighborhoods. That we don't have enough primary care doctors. So lots and lots of things. So looks like we lost Yolanda again. I think she's coming in on another way. So, but Anne, anything? Maybe it's a good time to talk about the Texas legislature.
Well, yeah, there's one of the things that I wanted to, and I'm very sorry that Yolanda's not here because I very much wanted to hear her thoughts about this. One of the things we deal with in our organization, and I'm sure lots of participants on the call do too, is we're living in a world where we have a couple of younger generations than me, maybe even 3 at this point, but at least a couple, who very much are totally on top of, being dedicated to reducing racial and ethnic disparities and pursuing equity and seeing how structural racism affects public policy and how a decision like Texas to not do Medicaid expansion, because 74% of the people it affects are people of color, is an example of that. It's not like the governor and the legislature sat down and consciously thought, we're not going to do this because it will help Hispanic and Black Texans. But that's what, when we talk about institutional racism, we're talking about sometimes unconscious, biases and decisions that have been built into public policy. So I'm dealing with a couple of younger generations who are all over that. They totally get it. When somebody comes in to apply for an internship, they can talk about that better than I can. I promise you. But on the other hand, we're dealing with, in some cases, a generation or maybe even more older than me at the legislature too. And many of them, I can promise you, they are not yet barely dipping a toe in the national conversation about structural racism and bias in the health system and the disparities that come out of that. So one of the challenges we have is, how do we meet all of those expectations? And, the expectations of the many younger folks who have sent people to the legislature to make change, but also try to meet this older generation of disproportionately white male legislators where they are, and educate them in a way where they don't stop listening immediately. And I think that's not, it's one thing for all of us on this call to really understand the power of all this data about how serious the problems are and how real those barriers are, and to remind people that you cannot move up the economic ladder if you're completely overwhelmed by, not only can you not stay healthy and take care of health conditions, but you also can't move up the economic ladder. So we've got, all of us are on message on that, but how do we take that message to our broad, diverse, around legislators in a way that they can hear it. And there's going to be an expectation that there's a lot more talk about that this session. And so it'll be very interesting to see how we can bring that conversation up in a way that really can be constructive. I know we had at least one question in the chat box, which was very relevant, which is what happens to all of this if the Supreme Court strikes down the ACA, and then what's going to happen with Medicaid expansion. I'm just going to talk about the Medicaid expansion for a minute. We can come back to the ACA thing, but the good news is that there is much more broad discussion of Medicaid expansion. That discussion will include pointing out the racial and ethnic disparities that come from that, and we hope that that will be a positive influence, in moving toward it. We have very interestingly, in addition to a Democratic senator like Senator Johnson from your area in Dallas, as well as a number of Republican members, have gone on the record mentioning that this is going to be on the table. A couple of things, and there's actually a link to this on one of my slides, so look at the slides later. But there's a couple of new reports that the Episcopal Health Foundation of Texas commissioned, and one of them estimates the number of Texans who might sign up uninsured Texans who might get coverage, as well as and breaks it out by county, and then also projects how much new federal money we would get. Then there's another one that projects that the savings to state general revenue funded, state budget funded healthcare added to the increase in health insurance premium taxes would more than pay for the state's share to do Medicaid expansion. And those are gaining some traction and getting attention. So you see more Republican members talking about how, well, this is going to be on the table. So that is far from a done deal, but it's the most movement we've seen in a long time. And in a time of COVID, where the Kaiser Foundation is projecting that by January, at least 2.2 million uninsured Texans will potentially be in that Medicaid expansion population. And it may be more, because that's an estimate based on numbers from a couple of months ago. That all sort of softens the ground considerably for making progress on that. So I've talked my head off, and I should probably let my partners get a word in edgewise.
No, so Senator Nathan Johnson has talked quite a bit about the economic impact, and it's, he says it's a no-brainer. Forget about the moral imperative. Forget about it's the right thing to do. Forget about the racial inequities. It is the right economic thing to do, and Texas needs to do that. Yolanda, are you back with us?
Yes, I am. Can you hear me? Oh my gosh, I'm so sorry for all the
interruptions. I know we just have about 5 or 6 minutes left, so please.
Okay. So let me make a quick comment about what you both just said about the economic imperative, because I see a question in the chat here about how do we make a business case for this. So there is a large body of literature from natural experiments of states that have expanded Medicaid versus those that have not, that demonstrate that states that have expanded Medicaid will save money. The expansion actually pays for itself in many ways. One of them being, of course, increasing access to care, decreasing disparities, improving the quality of health outcomes, but also, like Anne just mentioned, balancing out some federal income, federal money coming on the table. It's been shown that, the cost of expansion supported by the state would be about 10%. Whereas if they had to apply traditional Medicaid to that same population, they would have to pay about 25 to 50% of the cost of care. So there is a case in many ways, whether it's through the quality of care or the balance of federal contribution versus state contribution for expanding Medicaid in Texas. And like we said previously, taking care of health disparities saves cost. That is, reducing those disparities save costs. And there's a large body of literature, again, that shows it. And I think it's totally up to us, right, the advocates, to pull that data together. It's not up to lawmakers to be sifting through it. Not sure if, they would necessarily wrap their heads around it in an easy way, but people pull the data and tell a story of how, like you said, as much as it's a moral imperative, it's actually also the right thing to do economically. So yeah, that would be the business case for it.
And the numbers are big. That the A&M study, which again, you can look at the slides and you'll see the numbers from it and a link to it. It's very conservative and is only projecting around 1 million Texans sign up for this coverage under Medicaid. And they say that would bring in about $5.5 billion a year in new federal dollars. But if it were twice as high as the Kaiser Foundation is predicting, if it were 2 million, you'd be closer to 10 billion with a B, additional federal dollars paying for healthcare services.
I also think this is still the business case, but a healthier worker is a healthier worker. You'll be able to work more. You will be have easier. An insured worker, for example, is going to have easier access to healthcare, right? It's going to be easier to get an appointment. You're not going to put off that care. You're not going to put off the preventive care. You're not going to have to split your pills in half so that they will last you twice as long. Just a number of different things. I have family members, I have friends that have really, really suffered without having health insurance. It is very, very real. All of us have been uninsured at times in our lives because most of the insurance coverage in this country is because of because of your employer. But there are times that some of us, are between health insurance. Now, when that happened for me, I was, a young kid and, invincible, and I don't need no health insurance, and I certainly don't need to pay for it. But man, the older I get, the more I appreciate good health insurance. It is very tricky to live this life, this country, without health insurance. It's very, very difficult. I have two relatives that had exactly the same health condition. The trajectory for the uninsured was extremely different than the trajectory for the insured. It was a breast mass for both, and they're both okay, thank goodness. And I hate to say it, but had it been the uninsured that had breast cancer rather than a super great insured, it would have been a different outcome. It literally is life and death. So.
That is true. That's totally true. And Leno, just to add to that, from a medical standpoint, we usually recommend that we spend a little upfront to prevent, so we don't have to spend so much towards the end of life, right? Because our social contract to each other is that we can't let someone die in the street. We're going to pick them up and we're going to take care of them in their dying days. But we could have actually spent much less money in preventing them from getting into that situation and having a productive person that would have brought a lot into the community by spending much less. So that's just part of the argument.
Yolanda, I'm glad you're back online because you get the last word. So thank you. I'd like to thank Ann Dunkelberg for your wise words, and Yolanda Pingrazzi, and also Tom and Summit Financial Group for making all this possible.
Thank you.
Thank you, Lenore.
And vote.